Let's move on to the next session. It's a case-based discussion. Dr. Harsha Devarbhavi will be moderating this session. And the panelists for this session will be Dr. P. N. Rao, Dr. B. C. Sharma, Dr. Prateek Poddar, Dr. Preetham Nath, and Dr. Naveen Ganju.
I would like to echo what others have done before me, and that's to thank Ajay. So I thank Akash Shukla as well as the organizing team for their kind invitation. So let's head straight away with the case. This is a young adult with acute hepatitis and cholestasis, and who has also history of CAM. And I also thank my co-panelists for taking part in this discussion. So let's start with this case, and this is a 23-year-old boy, born of consanguineous parentage, went to a local doctor feeling unwell for 3 weeks. He had decreased appetite, itching, dark urine, but had no diarrhea. And on examination, he had scleral icterus, his itching marks, he was afebrile, and the liver was palpable. And this is the liver function test over a period of a few days or 1 month. We find that the total bilirubin gradually increased from 3.2 to about 11 in about 1 month's time. AST rose to about 4 times abnormal. ALT again about 3.5, 4 times abnormal. Alkaline phosphatase mildly elevated and GGT significantly elevated. Ultrasonography showed the liver showed mildly enlarged. Gallbladder had showed few calculi measuring between 5 to 15 millimeter. CBD was normal and intrahepatic bile ducts were normal. Spleen 10 millimeters. And MRCP corroborated the same findings, gallbladder stones with no obstruction. So my question to Dr. B.C. Sharma is, what's your differential diagnosis and how would you go about with this case?
This young adult at short onset hepatocellular cholestatic jaundice fits into either acute hepatitis, acute exacerbation of chronic liver disease, or superimposed acute insult of other etiology on pre-existing chronic liver disease. Going by this presentation, I will first like to discuss possibility of BRIC. BRIC, first episode in young adults, and disease over weeks to months is known. All the features, jaundice, cholestasis, LFT, normal ultrasound, normal MRCP, fit into BRIC. However, in patients with BRIC, in LFT, GGT is normal. However, in this patient, it is raised. Therefore, I will not keep the possibility of BRIC. In BRIC, GGT is raised because in BRIC, GGT is normal because in BRIC, basic is bile salt transporter pump defect, which does not injure bile duct, does not injure bile duct epithelium, therefore GGT stays normal. Whenever I talk of BRIC, I should consider other causes of benign intrahepatic cholestasis. And thinking this patient's history, 2 possibilities come in my mind. First is PFIC3. Due to BRIC and PFIC3 have common genetic abnormality and heterozygous mutation. Therefore, their clinical features are always mostly same. And PFIC also can present in young adulthood. And main difference is in PFIC, GGT is raised because in PFIC, the bile salts are insoluble due to deficiency of phospholipid in the bile, and this insoluble bile salt is toxic to bile duct epithelium, leading to inflammation and cellular proliferation.
Dr. Sharma, we'll talk about the pathogenesis a little later. I've almost, we're into the 3rd slide and we need to move faster. So if you can just mention the other differential diagnosis.
Yeah, other differential diagnosis, I will consider it. Third is PFIC3 will be my first possibility. Second possibility will be a drug-induced liver disease because histio-CAM is there. The timeline before, after illness, during illness, that is not clear. What was the indication? How long it took? Drug was labeled, unlabeled, or mislabeled, that is also not clear. However, he has taken the CAM, and after that he has jaundice. How drug-induced jaundice we can rule out by, it is a diagnosis of exclusion. We can rule it out by ruling out acute viral hepatitis, alcoholic hepatitis, metabolic liver disease, and autoimmune hepatitis. But I will still keep this possibility.
Thank you.
Points, sorry.
You have one more
Wilson's
time?
and autoimmune.
Wilson's, okay.
Wilson disease, points against are that cholestasis in the beginning is against, and in Wilson's disease, alkaline phosphatase is not raised. In this patient, it was raised because in Wilson disease, copper overload incorporates into the zinc of alkaline phosphate aposynthesis enzyme. Therefore, when copper incorporates, it makes this enzyme inactive. Cholestatic phase and raised alphas are against Wilson's. Autoimmune hepatitis, all the features fit into the autoimmune hepatitis. However, predominant cholestatic feature does not fit into autoimmune hepatitis.
So I'll give you the
Acute
investigation.
presentation, just 2 lines. Acute presentation, acute hepatitis, acute severe hepatitis, ALF and ACLF can present in 21 to 43% cases of autoimmune hepatitis. If I have to think of cholestasis, then I have to keep the possibility of overlap autoimmune hepatitis with PBC or PSC. However, overlap syndrome never presents with acute presentation. They do not have this kind of acute presentation. Therefore, autoimmune hepatitis from my side is also out.
Yeah, thank you. I'll go to the investigations. I'll go to the So these were hepatitis markers, hepatitis A, B, C, E, EBV, CMV never negative. ANA was 1+, ASMA, LKM, AMA negative, IgG was 1512, bile acids were more than 500, serum ceruloplasmin, 24-hour urine copper and KF ring. KF ring was negative, ceruloplasmin was high, and copper at 24 hours was mildly elevated. So my next question to Dr. Rao is, we see this quite often, 1+ ANA and a lot of abnormal liver function tests. So my question to doctor, what is the significance of 1+ ANA?
Let me be brief, First thing is you should know which test you are asking for in AFP, in AN. That is it an ELISA, which gives you just a number, more than 1 or less than 1, which is more sensitive but less specific and more false positives. Next thing is to know, is it an IFA, which is the one which is recommended, which we should all use it. Indirect immunofluorescence, there are 3 components are there. The plus indicates the intensity of the immunofluorescence. The most importantly, the dilution which you have to look at it is 1 in 40, 1 in 80 are the ones which is the simplified AH, it gives a 1 point and then 2 points there. And another thing is what is the pattern, which is a homogeneous pattern. In case you are suspecting other organs involvement, other autoimmune diseases, there is a reason to do ANA blot. But to know what are the non-specific elevations is the most important in deciding whether it is related or unrelated to the existing problem which we have. Thank you.
Okay, and then to fellows here, ANA 1+, 160 is very common in the general population. And even LKM is seen in about 1% of the population. So please bear that in mind before you make a diagnosis of autoimmune hepatitis. And then the range of anti-nuclear antibody positivities, you can see this 1:40 in about 32% of human beings in the world. And 1:30 is seen in about 3.3% of population. So again, just only 1+, 2+, 3+ does not make autoimmune hepatitis make. So my question back to Dr. Sharma is you have to be very brief that you have got all these investigations, so you can narrow down to a couple of differential diagnoses.
Yeah, differential diagnosis, BRIC, you have kept the first possibility. I have already ruled it out because in this patient, GGT was raised. In BRIC, GGT. If we keep the BRIC, PFIC3 comes automatically. That is the most important point in this. GGT was raised in this, that is raised in PFIC3 also. And serum bile acid investigation were also very high. So everything is in favor of PFIC3. Second, you have not mentioned drug-induced liver disease, but second possibility, I will like to keep that because in this patient, acute hepatitis, autoimmune hepatitis, it is not an alcoholic consumer, and metabolic liver disease we have ruled out. So drug-induced hepatitis in patient who has taken histio-CAM will come out.
Thank you. For others, yes?
Sorry, autoimmune hepatitis, PSC cannot be overlapped because patient has acute presentation. Sure. Wilson disease, all copper parameters are negative.
Out, yes. So yeah, as also often happens, we need to dig very, very much into the drug history. And lo and behold, this person took itraconazole for tinea cruris for about 15 days, followed by weekly doses for about a month, for a couple of months. And also he took nutritional supplements, and I'll show you the photographs here. And these are the nutritional supplements he took. So my question to Pratik is your thoughts on the drugs that the patient was exposed to, and what do you do next?
Like we've discussed the differentials already, and drug-induced liver injury is very high up on our list of differentials. Of course, both azoles, itraconazole is well known to cause drug-induced liver injury, idiosyncratic reactions, cholestasis. Of course, along with that, we have that these protein supplements. Now, the most important thing here is the content label mismatch, which has been highlighted both in the Western data, around 40% showing the label and the content mismatch, and around 70% in the Indian data, Dr. Phillips' data, which is 70% having label and content mismatch, which can actually have heavy metals, which can have herbal supplements, and herbal supplements importantly causing cholestatic liver injury, which is very common. So this is very important for us. That is one thing. And of course, we have the overlap or even small duct PSC. So I think next thing we can think of these things and we can go for a liver biopsy in this patient if required.
Thank you. Thank you. So this was when the patient came to us, and then this patient was subjected to a liver biopsy. And this is what we saw in the liver biopsy. And Dr. Naveen, your thoughts on the liver biopsy?
So we can see in your slide, you can see canaliculaar cholestasis and lot of inflammation there in the portal tract. What we can actually appreciate here is there is inflammation, but there is no bile duct kind of seen here in this biopsy. But the CK7 stain, CK7, CK19 stain, you can see some biliary reactions, but there are no proper bile ducts seen there.
So yeah, so the portal areas you don't see any bile ducts, but then the periportal area you see the hepatocytes taking up CK7. So so the diagnosis was histological diagnosis vanishing bile duct syndrome. So Dr. Naveen, you want to
so vanishing bile duct syndrome can be drug induced also. There are some genetic things as well. So in this case, you see it is kind of a histological diagnosis per se, where you have, as we say, adequate biopsies around 10 to 12 portal tracts, if you can see in a biopsy. In that, if 50% of the bile ducts do not show a bile duct, or there is paucity of bile ducts, then you call it as a vanishing bile duct.
And a whole list of drugs have been listed here,
Yes,
so
yes,
which can lead to
many
vanishing
drugs
bile duct syndromes. And the other terminologies are drug-induced cholangiopathy, bile duct injury, drug-induced ductopenia, and disappearing intrahepatic bile ducts. So this patient was, because he had these features of cholestasis, the primary physician subjected this patient to whole genome sequencing, and lo and behold, this is what he got. ABCB4, MDR3 was homozygous. But then if you look at the inheritance patterns, is it autosomal recessive? He was 24 years old when he got it, and the classification is uncertain significance. As Dr. Sharma mentioned, this looks like PFIC3 or BRIC3, but then this enzyme mutation that has been detected in this patient is of uncertain significance. And I'll come to this a little bit later if we find time. Now, this is the philosophy that I want to just drive home, and this is that a lot of us not all of us don't produce the same amount of transporters, but we can have a perfectly normal life with even up to 50% transporter functioning. So something, for example, a trigger like a drug or an environment trigger occurs, and when that occurs up to a hormone, you find that suddenly the amount of functional protein or transporter decreases to about 20-30%, then only you develop the disease. For this, you should have a baseline mutation of the transporters, either import or classically the export transporter. So this is for BSEP, which is about 50%. But then if you look at MDR3, which this patient had, then you tend to develop a disease even when you have about 50% functioning protein. So it's a much higher level than for BSEP. So remember that all of us produce different amounts of protein, but some instigator or some trigger triggers a sequence of events which make the production even lower down, and then you get what is known as called classic cholestasis. Now this is a diagram which tells you about different transporters, including the biliary canaliculi, and you'll notice that the MDR3 or ABCB4 is related to phosphatidylcholine. So once this phosphatidylcholine is not excreted into your bile duct, the bile become very toxic. And because it's lipids, also the cholesterol doesn't get absorbed too well, and these patients go on to develop what are known as cholesterol stones. And this patient also had low phospholipid associated gallbladder stone. So this patient had two problems. So a host of drugs are known to inhibit several transporters, and I've just listed them here. So always be careful and always take this history, because sometimes patients can take drugs, forget about it, and patients can develop a mild sort of cholestasis, which resolves by themselves when the patient stops the drug. So my final question to is Preetham is, how do you treat these patients?
The treatment, the first is of course stopping the offending drug if it is not stopped yet. And it's followed by ensuring a proper nutrition. These patients may be cachectic, and symptomatic treatment of pruritus with antihistaminics. And if the patient doesn't respond, then they can be treated with cholestyramine or sertraline, SSRIs, or maybe rifampicin. And orthotoxic acids, they are universally used in these agents, but benefit is uncertain. But there are certain reports that it may reduce the apoptosis in hepatocytes. Immunosuppressives, corticosteroids can also be used, and the benefit may be uncertain in certain literature, but they definitely have a role in intractable pruritus. And if the patient has severe liver disease, then he may require liver transplantation.
The audience, do you any thoughts on how we should treat this patient? One is withdrawal of the drug, yes. What about UDCA? Any other mode of treatment? So yeah, this patient was on UDCA but he still did not improve, and he took it, and he continues to still take it. But then his question was whether we should start steroids, and we all do, because for want of better drug, we give these patients 40 milligrams of steroid. And I've always been fascinated about steroids. There is hardly any inflammation in the liver biopsy, but yet patients do respond if you give them steroids. And that's because steroids tend to stimulate CYP2E1 as well as enhance also MDR3, which increases the excretion of bile salt. So steroids has dual action. It increases or stimulates CYP2E1 as well as stimulates MDR3. So the patient was put on Visolone for over 2.5 months, 3 months, and then this is when he first came to us. Liver biopsy followed by steroids, and over a period of 2.5, 3 months, his bilirubin gradually normalized, and at the end of 9 months, you find that the patient still has a bilirubin of 1.8 and the enzymes that are just above normal. So my final slide is about this. You don't see this very often, but then this is the drug-induced liver injury network experience of 26 patients out of the 363 patients who had a liver biopsy from DILI as well as HILI, and that's about 7% of patients. So 50% develop mild liver injury, 50% develop severe liver injury. The most common presentation is severe cholestatic hepatitis. Then about at least a third or a quarter of patients tend to die because of the severity of cholestasis. You need to replace the liver. And then the poor outcome of predictor is the degree of bile duct loss. Fortunately, this patient, despite having a significant bile duct loss, responded very well to UDCA as well as steroids. So, and on that note, you have finished well before time. Thank you very much.
Dr. Dev, sorry, ABCB4 are positive, and that is positive both in BRIC and PFIC3.
Correct.
So therefore, because GGT was raised, and this genetic abnormality and this mutation is same in both the conditions,
Correct.
I will prefer the possibility of PFIC3 over BRIC.
So this is basically BRIC. The patient has underlying BRIC because we have the genetic analysis, which was precipitated by the ingestion of drugs, including the itraconazole plus or minus the herb or the protein supplement that he took. So as we all know, there is some trigger that predisposes this patient to manifest with disease. This is the autosomal recessive mutation. He had it since birth, but it's only at the age of 24. So some trigger that occurred, and that trigger was the drug-induced liver injury due to itraconazole / a herbal or dietary supplement.
One of the presentations, like immune-mediated drug-induced liver injury, some underlying disease is there, and drug precipitates that, and that patient presents with mixed features of drug-induced and underlying disease.
So that is
this patient had PFIC3, and drug injury has precipitated, and patient presented manifestations of both them.
If this patient had some amount of inflammatory cells, then that is possible that these inflammatory cells or their metabolites go and destroy some of the biliary canaliculi. So through an inflammatory component, these patients tend to develop drug-induced liver injury. But here it is not the inflammatory component, it's the blockage of the biliary transporters. Thank you.
Thank you, sir. Thank you, everyone. We move on to the next session, and before that, I would like to just remind everyone that 7:15 p.m. onwards today, we are going to have an interaction with a few famous sports personalities. So please do attend. For the next session, I want to invite the chairpersons, Dr. Saroj Sinha, Dr. Ubal Dos, Dr. Manish Bhatnagar, and Dr. Nitin Ramani. I request them to introduce the judges and the speakers for the debate session.
We have very interesting debate in the next session, and this is highly clinically relevant, and we have very eminent speakers for that. And the debate is going to be about liberalization of indication of treatment of hepatitis B virus infection is the best way forward. And for the motion, Dr. Anil Arora is going to talk, and against the motion, Professor Rakesh Agrawal is going to talk.
Can I invite the judges also, Professor Subrat Acharya and Professor Anil Anand, sir. Welcome, sir.
Clash of two titans. Subject has already been said. I approached Akash to ask a question that why have you kept the topic so vague? There are several grades of liberalization. Grade 1 is what APASL has done. Grade 2, what Chinese guidelines have done. Grade 3 of liberalization is what WHO has done. And grade 4 is what many experts here say, that every patient who is surface antigen positive should be treated. But I think by consensus, both the speakers have agreed to choose dividing line at the Chinese guidelines. Is that correct?
Partly, yes.
Okay. So that is the dividing line, Chinese guidelines. And before we ask them to speak, let me see how many audience feel that we should adopt Chinese guidelines. No one. So let us see Anil Arora, what he has to say.
Most of the
Chinese
people
guidelines are every patient with HBV infection who is DNA positive should be treated. Just about 5 people.
The reason why they have chosen this, because in China it is endemic and the genotype is different, the prevalence of cancer is high, that's why they have chosen. Right, it is region specific. And also the controversy have started after World Health Organization has actually liberalized in 2024. And that's why INSL has also liberalized it, Anil had headed it. So there is a debate still going on, but people are preferring to treat. And particularly there are now studies, I think Anil will present that, and particularly Gambian studies, which have become very famous studies, which says it is more cost effective and years of life saved is more, right, DILI is more, all those things. That's the reason why.
Dr. Anil Arora.
Thank you, sir. At the outset, I am extremely thankful to Akash and his team for giving this opportunity. The topic which was allotted was liberalization of the indications for treatment of hepatitis B. What is the best way forward? But somehow down the line, Rakesh had insisted on trying to marginalize the indication. Now, all of us know that the goals of therapy for treatment of hepatitis B are primarily in the form of achieving an end point, which is a suppression of the DNA, which is the only thing which is possible with the current therapy. You also have valuable endpoints in trying to attempt an loss of E antigen, trying to normalize the ALT, and finally, and obviously, the optimal endpoint is the loss of HbS-AG with or without conversion to HbE antigen. If I stick to my dear friend Rakesh and follow all his guidelines, it's very important to remember, irrespective of what guidelines you look at it, whether it is ASLD, APASL, EASL, INSL, or US guidelines, you bank upon three parameters, that is ALT, DNA, and the liver inflammation, and try to see how to treat. And if you want to have a simpler look, just take a lens and look at a person who needs to be treated. So you just need to see that the only thing which needs to be treated in presence of DNA is an elevated ALT. So very easy. If you have raised DNA, raised ALT, treat the patient. But what do we have to offer the treatment? We have hundreds and thousands of the guidelines. We keep on arguing about them. We keep on fighting about them as to, and what are we offering to the patient? In fact, as in 2024 and 25, we have very limited therapy to offer to the patient. And these therapies include entecavir and the derivatives of tenofovir, and pegylated interferon is practically out. So what have we achieved with these guidelines till date? So we know they suppress inflammation, we know they try to attenuate the DNA level, and they tend to lose the E antigen, but the loss of HbS-AG is dismal. So this is what we've achieved in the guidelines. We only try to normalize the ALT, we try to have HbE-AG seroconversion, we try to normalize the DNA, but HbS-AG loss is pretty dismal with whatever we do. So for the time being, if I stick to what guidelines we have been following up till date, we have achieved almost nothing over the last 20 years. And that is the reason I think the judges and the panelists have put up against a fight. And both of us being classmates, Rakesh Agarwal being this, more celebrated personality, they have put it on a mat for fighting. And let's see, if I simply follow what Rakesh is saying, that just stick to the guidelines, and we have been sticking to the guidelines diligently and intelligently for the last about 20 years. What have we achieved? Only 10%. Do we have the pointer, please? Is it possible to point out? Where is this? Okay. Yeah. So what have we achieved over here? Only 10% of the patient overall in the world, they know they have hepatitis B, of which only 2% are treatment. This is all across the world. That means only 20% of the patient in the world know they have hepatitis, majority are undiagnosed. And even if they are diagnosed, because of our strict and stringent guidelines, only small percentage is treated. This is not only in the Eastern world or in the underdeveloped world. Even in countries like developed countries like US, we have 20% of the patients who are diagnosed. Of these, significant proportion are not even aware that they are having suffering from hepatitis B. And even if they are suffering, we put on our own stringent condition of treating and not treating them. So this is across the generation, this is across the total different type of population, including Africa, Asian, as well as in the US. So if I simply follow Dr. Rakesh Agarwal, this is what I'm going to achieve. 20% of the patients will know they have hepatitis B, 10% will benefit from the treatment, and of those who are given treatment, 60% will be compliant to the treatment, and of those who are compliant to the treatment, 60% will respond. But then, while writing the guidelines, do we ever consider these issues that the patient have psychological issues? They are worried about development of HCC, they are worried having anxiety and depression. They are concerned about the transmission to the families and to the children and the spouses. This is associated with stigma, and every time the patient has some other symptom, he may end up attributing the symptom to presence of HbS-AG. In addition, if we strictly follow the guidelines which have been published all across the globe, there is good 30% of the patient who will not fit in with the guidelines. Dr. Rakesh should understand that as doctors, Rakesh and me would understand the guidelines, but the virus has not read the guidelines. So virus will not fit into the particular type of data. And overall, 30% of all patients, with hepatitis B do not fit in with the guidelines which tell you to treat or not treat. So there is a huge chunk of 30% of the patient who are in the so-called gray zone. What is this gray zone and what does it mean? In fact, a good study published recently in 2023 had shown that almost 40% of the patient with hepatitis B will fit in with so-called gray zone. And of these, if you keep on following them up, Rakesh will tell us, oh, if it is a gray zone, why don't you follow up? Mind you, if you keep on following these up patient over 10 years, 52% of these patients will continue to be in the gray zone. And what is this gray zone? This is the area of the gray zone in which the ALT may be high, DNA may be low, or DNA may be high and the ALT may be low. So this is a big chunk of the patient. And in this subgroup of the patient, if you see, if you give antiviral therapy, there is a good data to show that you can have 70% reduction in HCC. So just by sticking to the guideline and say, oh, this is gray zone, keep on waiting, we are exposing these patients to development of HCC in subgroup of the patient. And we should also realize that when we write the guidelines, it does not take into consideration the age, it does not take into consideration the sex of the patient and the quantitative HbS-AG, which is so important. So so-called intermediate zone of the hepatitis B, if it is treated by antiviral therapy, there is a 70% reduction in the HCC, which is so important and is one of the most important causes of mortality in this subgroup of the patient. We should also understand that when we are talking treatment of hepatitis B, we should remember even WHO has classified hepatitis B as a class 1 carcinogen. So it is not a level of ALT, it is not a level of DNA which needs to be treated. We need to treat the infection holistically. And let's hope we believe all whatever have been published. And this is a good data of 364 people with chronic hepatitis B. We were followed up over, and of these 161 developed HCC. About 40 to 50% of the patients who were rejected by these guidelines because they were not treatable for flimsy reasons like not fitting with ALT, not fitting with DNA, 50% of these patients developed hepatocellular carcinoma. I wish if somebody would have treated, this would have been prevented. Another Korean data which has shown that 3,624 patients followed up over a 4.6 years of patient follow-up, they have shown that HCC developed outside treatment criteria according to 50% of the patients. That means if you keep on just refusing treatment because they are not fitting with the so-called compartmentalized stringent guidelines, a substantial percent of these patients will also develop hepatocellular carcinoma. Reveal study, everybody knows that higher the level of HCC, higher the level of HBV DNA, there is a direct low correlation with degree of development of hepatocellular carcinoma. It has been clearly shown that even in so-called low-risk patients, in which the conventional guidelines will forbid you from giving the treatment, there is a substantial reduction, not only in the US, but also in the Reveal study, there is a substantial reduction in development of hepatocellular carcinoma. In fact, it has also been shown that outcomes in untreated HbE-AG positive patient of infection, patient who are in having a treatment versus targeted versus untargeted treatment, both the development of HCC or death from liver transplantation in cohort of the patient who were given treatment with antiviral drug across the studies has shown that there is a substantial reduction in treatment of development of HCC as well as the death and the liver transplantation need. Moreover, whenever we talk of development of hepatocellular carcinoma, we never talk of HbE antigen and HbS-AG quantitative level. These, in addition to HbS-AG, also contribute to development of hepatocellular carcinoma, which none of the guidelines try to look into it. In fact, it has been shown that patients with so-called low viral replication, we talk of a chronic inactive phase in which the HBV DNA is less than 2000 and HbE antigen is negative and ALT may be low lying. This may be still moving at a snail's pace, and it has been shown that 13% of these patients, when followed up over a period of 1 year, will tend to develop hepatocellular carcinoma. So not all low replicative patients, not all low replicative patients with hepatitis B are likely to be having a benign disease. The argument which has been repeatedly put forward is, oh, this is a immune tolerant phase, it is better not to treat. But do we even know what immune tolerant means? In fact, there are variable definitions of immune tolerant. We are still not sure whether this patient should be at the age of 40, 35 or 30. Different international guidelines have their own cutoff. We do not know what should be the cutoff of DNA, but the only thing which needs to be done is patient has to have no inflammation in the liver. You need to have a persistently normal ALT, and still we do not know what is the normal ALT, and there should be no injury to the liver. In fact, if you follow these patients, most of the guidelines have shown that majority of the studies which have included so-called immunotolerant patients do not have strictly defined immunotolerant patient in this category. Even there is a discrepancy in the ASLD and EASL in trying to define. ASLD says that an immunotolerant patient is one who does not have significant necroinflammation. That means it is looking at the patient's perspective in terms of the inflammation. Whereas if you look at the EASL, what it says is that there should be, irrespective of the severity of the histology, if you are more than 30, DNA is positive, treated. So even ASLD and EASL differ in perception of so-called immunotolerant. Whereas ASLD thinks it is inflammation, which says if it is absent, it is immunotolerant. Whereas EASL thinks the fact that you are having DNA, irrespective of inflammation, you are having immunotolerant phase. Is immunotolerant phase a totally benign disease? The answer is no. If you follow up these patients with so-called immunotolerant phase, 15% will develop ALT, which is elevated over a period of time. 5% tend to develop cirrhosis of the liver. And if the age is more than 35, and you are likely to have other complications like cirrhosis and hepatocellular carcinoma, which tend to develop with passage of time. In fact, there is a so-called inflection point up to the age of 30 years. Immunotolerant is acceptable, but anything beyond 30 years, there is a higher incidence of development of hepatocellular carcinoma, even in immunotolerant phase. So what should be the cutoff in defining immunotolerant phase is very important. And one cannot have a strict guidelines that if you are immunotolerant at age of say 35, you will not develop any hepatocellular carcinoma. The reason is that HBV contributes to hepatocellular carcinoma by a plethora of mechanisms. These include accumulation of the DNA, mutation in hepatocytes. HBV DNA tends to incorporate into the host genome and produces oncogenes. There may be epigenetic effect of the hepatitis B virus. There is modification of the DNA resulting in alteration in cellular signaling and viral pathways. There is development of basal core promoter mutation, and the microenvironment which changes because of the presence of the cytokines and oxidative stress all leads to clonal expansion of the hepatocytes, which is important for development of hepatocellular carcinoma, which is so important in causing death of these patients with the hepatitis B virus infection. So in addition, patients who are in the immunotolerant phase, they are also likely to have integration of the virus as early phase of the hepatitis B.
Anil, request you to start wrapping it.
And finally, reduction of HBV DNA, even in immunotolerant phase, decreases integration of the virus. So I'll stop at that. I'll have few slides for rebuttal. So to summarize, I think if we want to treat patient with hepatitis B, it is important to understand that we should not be dealing only with one parameter like HBV DNA or ALT. We have to look at the virus at totality before deciding the therapy. And the indications for treatment should be far more liberal, otherwise we'll be sticking up with very few percentage of the patient will be benefited with our therapy.
Yep, please join us here, Anil. Dr. Agarwal, please.
You have to define. Anil has given a lot of data that few patients are diagnosed, still fewer patients are treated, a lot of patients are not treated. If you don't treat, they develop cancer. If you treat, 70% of them die, cancer reduces. The first thing what he says treated, but how to get this targeted population, diagnosis, access to diagnosis, link to diagnosis.
I have my slides.
Also important.
My slides.
The act of shaking hands before the debate means that you have colluded with each other. Okay.
May I have my slides, please? Good afternoon, friends. Anil and I go way back, 1st of August 1978, when we met in the dissection hall as young medical students. It's 47 years, Anil, and I can assure you we will be here to debate the same topic 3 years later when we complete 50 years of knowing each other. May I have my slides, please? Sorry? That's okay, that's okay. So, let me So if I were to say the points that Anil has made, he's made 2 or 3 major points. One, that very few are being treated. Yes, but does that mean we start treating everybody? Okay, so here are my slides. I can see them. No, I just want to indicate to them that I can see them, they are here. Yeah. So that's the topic that you saw on the program. To understand what we mean by liberalization, though to some extent General Anand has already done that, there are these 4 phases that Anil showed to you, and there are 2 phases where everybody in the world agrees that we treat people. Also, in the inactive phase and reactivation phase, if people have cirrhosis or liver cancer, we treat them. But there are 2 groups that we don't treat, and that is immune tolerant and inactive phase. So when we looked at liberalization, the question was, what does it mean? Everybody is clear. It means treat more than what the classic indications can say. And there are several options, and beyond what the judges said, it could also mean treat acute hepatitis B, treat hepatitis B infection in infants, for instance. And so we had an alumni meeting of people who had joined medical school in 1978, where Anil and I met, and we jointly decided that we would instead change the topic, and the proposition would be all persons with detectable HBV DNA should receive antiviral treatment. So that basically means we are looking at 2 groups, the immune tolerant and some of the immune actives where DNA is still positive. Now, let me deviate from hepatitis B and look at general principles of infectious disease treatment. We treat people with infectious disease to ameliorate or shorten the duration of symptoms. We treat them to prevent progression or complications, to improve quality of life, prolong survival, sometimes to reduce the risk of transmission. To get rid of the organism if none of the above is present? Hardly ever. And let me give you some examples of people who harbor a pathogen but do not receive treatment. And mind you, several of us in this room, including me, may have infection with CMV, EBV, varicella zoster virus. The viruses are persisting in our body, we don't treat them. Many respiratory, GI, acute pathogens we don't treat. Clostridium difficile, unless it causes a particular manifestation, we don't treat. Benefits must exceed the risks, which are adverse events, cost, and drug resistance. So let's first look at immune tolerant phase. Does that fit in? We don't treat this as of today, except for certain special situations. So I'm going to talk about a run-of-the-mill patient with immune tolerant, not these specific situations. 3 arguments, and my friend Anil made all the 3 points. Reveal study data. People in immune tolerant stage can progress to progressive liver disease and fibrosis, and that we have very safe and effective drugs. Let's look at these one by one. Reveal study. Viral load higher, you have a higher risk of hepatocellular carcinoma and of cirrhosis. Yes, that's true. However, does this apply to immune tolerant state? If you see, the highest level they are talking about is more than 1 million copies, which means more than 200,000 IU per ml. That's the immune active state range. The immune tolerant range is 10 to the power 7, 10 to the power 9 IU per ml, and that's very small number of people, and we don't have data separately for them. The median age of this group was 45 years in that study, and 85% were HBeAg negative, which are not features of immune tolerant disease. Secondly, the REVEAL study data had HBV data levels measured at the first time point, at study entry. That doesn't mean that they continue to have those titers throughout the study. And if you look at people who are in this range at study entry, which today comes to 2,000 to 20,000 IU, depending on whether, and for some of those where data at follow-up was available, in those where the titer had declined over time, there is hardly any increase in the risk. Risk remains high only in those in whom the titers continue to remain high. And the same is true for those where the baseline levels were 10-fold higher. Again, if your levels remain high, then your risk is high. If your levels come down, your risk decreases. Third, those data are for genotype B and C, and those results may not apply to us where genotype is A and D. The second proposition, patients with immune tolerant stage can have progressive liver disease. And so I'll quote the same study that Dr. Arora quoted. So this was a 5-year follow-up of treatment-naive immune-tolerant hepatitis B patients with a mean age of 31, somewhat older than what we see in India. They had DNA more than 10 to the power 7 copies. They did not take alcohol. At initial biopsy, it was F0, F1. When they followed them, they found elevated serum ALT occurred in 9. So they went into immune active state and they would have been treated. Others continued in immune tolerant state. And when a liver biopsy was done at 5 years, only 3 showed progression. That doesn't necessarily mean cirrhosis. And fibrosis progression rate was very low. And if at all it was something that progressed, it was in those who became immune active and not in those who continued to remain immune tolerant. We have very safe and effective drugs. Is it? So if we look at treatment-naive patients who have a very high viral load in the immune tolerant state, their mean HBV DNA in this study was 8.4 logs. They were randomly assigned to receive either TDF alone or TDF with emtricitabine for 4 years. That's a long duration. And we find that DNA change from baseline in log scale was similar. So at the end, those who have a high viral load still continue to have virus multiplying despite this treatment, even if you combine 2 drugs. So HBV DNA, they looked at 2 cutoffs. If you look at the cutoff below 30 or below 70, we find that only 45% or 55% of those who get TDF alone, that's what we use. We don't use a combination. More than half still continue to have viral multiplication. HBeAg loss and HBeAg seroconversion were very infrequent. So, and later in a subset of 52 people, they stopped drugs and washed them over 24 weeks. Nearly everybody showed a rapid rise in DNA levels. So we cannot extrapolate the results of immune active phase treatment to the immune tolerant phase. These people don't have a body, does not mount an immune response, viral load is higher. So in spite of treatment, they will continue to have viral replication, which is, as we know from AMR, associated with a risk of resistance developing. Also, they are going to live longer because they're generally younger. So there is a greater risk of resistance. There is a risk of long-term toxicity and also treatment continuation. So we heard that 60% is the treatment continuation rate, 40% drop off. So if you start treating these people, what is going to happen? I can only imagine. Let's come to inactive phase. These are HBeAg negative, anti-HBeAg positive, anti-HBe positive, and have a very low viral DNA, usually less than 2000, very little inflammation. Yes, at biopsy, they have more often fibrosis than the immune active stage, but that's pre-existing. Does it worsen over time? And I've put here 4 studies having several hundred people followed for 5 to 12 years in different parts of the world, including in Taiwan, showing that the progression of disease is very infrequent. I cannot go into individual studies for lack of time. So there is no data to show, there are no data that if you treat them, there is benefit. Just because they develop complications, that does not mean that if you will suppress the virus, they would benefit. The usual argument is, we treat HIV irrespective of replication level, so we should do that for HBV. But in HIV, this is, the blue curve is what happens to the viral load, and red is what happens to CD4 count. Once an infection occurs, almost everybody goes on to develop chronic complications of HIV infection, whereas here in HBV, immune tolerant phase goes to immune active phase nearly universally, except a few. 90% of them have anti-HBe seroconversion. 10 to 20% can have immune active phase and then they go back. Others have an inactive phase, and that is what we are talking about. So compared to HBV, we have much better prognosis. The clinical progression is much less. In HBV, it has been shown that when you treat people with low viral load, you change outcomes. That has not been shown for HBV. Let's do it, then we will treat them. And then we don't have a vaccine. For us, we have a vaccine. So I don't think, based on what we have, we can justify long-term treatment with no evidence of benefit in this group of people. WHO and Chinese guidelines. So this is an extract from WHO guidelines. You don't need to read it. I'll magnify for you the relevant points. So there are 4 indications. The second one, HBV DNA more than 2000 IU and ALT above the normal limit. High certainty evidence when HBV DNA is more than 20,000, shown here in green. Low certainty evidence when the DNA level is 2,000 to 20,000. WHO is also now making guidelines on low certainty evidence. Lo and behold, the 4th one actually says very low certainty evidence. Recommendation is conditional. What do you mean by this? Chinese guidelines, they again look at ALT. But remember, if you look at the quality of evidence for each of these, it is B. And the criteria they use for defining as B is somewhat different from what other people follow. To me, between B and C, there is very little difference. So I really don't know what they mean by grade of evidence B. ALT. Yes, Chinese guidelines talk about ALT. We in this room must be careful. This study from PGI Chandigarh, Dr. Chawla is here, showed that in our blood bank donors, median ALT levels at different ages are close to 40. 50% of our people have values above 40. Let's not talk about 19, 29, etc. What is the basic reason why we want to expand treatment? We are treating only a small proportion of those who may need treatment. But is that the real bottleneck? The real bottleneck is we have a low testing rate, we have a low detection rate, we are not able to link them to care, and even when we try to link them to care, they are unwilling to take treatment, and there is low compliance. Anil himself said 60% take treatment over a long period of time, and we are not talking about 40, 50 years that we are talking about now. Yes, if we had a finite treatment similar to HCV, I would be here and defending, yes, liberalize, treat everybody. However, we don't have that. The drugs we have a temporary effect. They need continuous, infinite administration till you reach a funeral pyre or a casket. If the diagnosis is at 30 years of age, that would mean 40 to 50 years of treatment. Even in those who are currently receiving treatment, default rates are admittedly high. Default means risk of reactivation, worsening, cure of the disease worse than the endurance thereof, and there is a risk of drug resistance, especially if we treat large number of immune tolerants. All the available drugs act by the same pathway. So if you develop a resistance, it could be shared across drugs. Newer drugs, we have no good lead. Functional cure remains infrequent. People who are doing studies with those drugs are looking for patients whose HbS-Ag levels are extremely low. Is that a typical patient that we are talking about? Those are highly select people. If those drugs work, I'm willing, we'll change the paradigm, we'll go to treat liberally, but not today. Even the drugs in pipeline, the ones that are working the best, antisense nucleotides, remember, if drug resistance occurs, even those drugs, because they may be binding to the same place, may not work. There are several additional arguments. HBV-infected patients have viral integration, which increases the risk for HCC. The largest group of people that we are going to treat are those who are in the immune inactive stage, where integration, whatever has to happen, had happened, and none of the drugs that we have does anything to the virus that has got integrated, and that persists as such. Being on treatment makes an infected person feels better. That's what Anil said. Is that true in the long run? If they actually feel happy that they are getting treatment, then why are 40% people stopping treatment? And that's over a period of 4 to 5 years. If we have 40 years of treatment, I'm sure Their pocket will make sure that it will tell them that they are not happier. Treatment will prevent transmission. Where is the evidence? How many of people with HBV infection have family members who are infected? Finally, the title said, liberalization of indications for HBV treatment is the best way forward. Best way forward? For whom? For a physician. Yes. It is we who may feel better that we are doing something for the patient. Placebo for the physician, not placebo for the patient. Public health people who had to meet targets in WHO, they are not able to meet target of people being treated. You make the group bigger so that you can say you are treating many more million. Pharma industry, of course, a better bottom line. For the patient, I really don't think so. And let me, Anil, take you back to 1st of January 1980, the day we entered the clinical phase of our training. And Professor M.M.S. Ahuja, our professor of medicine, took the first lecture and read out to us this litany from Sir Robert Hutchison, who said, from inability to let well alone, from too much zeal for what is new, the antivirals, and contempt for what is old, from putting knowledge before wisdom, good Lord deliver us. And I still pray every day that good Lord should deliver me from doing some of these things. Thank you.
Dr. Arora, you get 2 more minutes for rebuttal.
Can I have the slides back, please? Thank you, Rakesh, for making the point. See, I think you admitted that there is a way forward to liberalization. We definitely have indications that at the moment we do not know what true immunotolerant phase is. And every time we have been talking, you are looking for evidence of prevention of transmission from husband to wife. Do you think somebody needs a proof for that? That is absurd. If the husband is positive, you say, where is the proof that it will not get transmitted to the wife? You are looking for a proof to that. Who will take it on face value? For something you don't need proof. You said, show me the proof it gets transmitted sexually, then I'll give the vaccine or I'll treat it. That's not the reason. Just because you will not treat it because DNA is not high. Do we ever understand the social stigma associated with it? Do we understand once it is integrated, there is no, after 30 years, you think the damage has been done, you will not do anything. For 30 years, you are not doing anything, and then you say nothing can be done. That is absurd. And I have shown you repeatedly to the virus which is getting integrated. How do you know without treatment? It's the clonal expansion does not increase, integration does not increase. Where does the integration come from? It comes from the multiplying virus. What you are trying to suppress is the virus. And we have good data to show the medicines which we have for the time being, they are totally safe. For 15 years at a time, there is a data, there is no resistance. And how do you know 5 years down the lane, we will have no more drugs which are going to be the futuristic therapy like we have in HCV? So why have a pessimistic attitude? Leave them alone. You have given an example of things like other infection like herpes which do not need to be treated. They don't hide in liver. They do not produce hepatocellular carcinoma. They do not produce cirrhosis of the liver. We are talking of a virus which can be suppressed completely. You have taken a clue that suppression from 10 million to 65 is not enough. What else do you want? In immunotolerant phase, your cutoff is, 67 has not been achieved from 10 million. Is that less of a suppression? I think that is a good enough suppression if you are achieving. Current antiviral medication therapy has been doing a good job for suppressing it completely. Fortunately, a simple drug like TAF, which is so cheap and easily available, compliances are a problem because we do not explain to the patient properly. And finally, my only
2
condition
minutes
is...
are over.
Yeah. Just because the older studies have not shown, and there have been problems of defining immune tolerant phase, defining ALT, rather than shutting them alone, we should be more liberal. The only patients who should not be treated as of today is those who are truly immunotolerant. Less than 30 years of age, persistently normal ALT, persistently normal DNA, high DNA, without any evidence of liver injury, no comorbidity. Show me few patients, I will not give them. Rest, I will still like to give them.
Thank you. Would you like to say anything for rebuttal?
So thanks, Anil, for accepting that all immunotolerant don't need to be treated. We'll start from there. So really speaking, if I go by your first sentence of your talk, you said we have very limited treatment options to offer as of today. And we now want to offer those limited treatments to more and more people. Fine. The point is that very few are being treated. We should be treating more. We could have done that with the existing guidelines by screening, by finding out more, by linking them to care. We haven't done that. And that is what is prompting us to try and widen. Those are the ones where we know the treatment matters. Let's first find those and treat them. Then we think of liberalization. Compliance is going to be a big problem. Do you know what are the hypertension control rates in the country? 12 to 13%. Do you think that we will be able to achieve anything? And as you yourself said, 60% is the adherence rate. If we take about 30-40 million people that we may have with hepatitis B infection, about 70-80% will have DNA positive, and we start treating all of them, assuming that our industry can produce so much drugs. How many will be cycling on and off the treatment every month? And what would we achieve? For these drugs, good adherence, even in those where they are indicated, is important, and we are not achieving that. I think those should be our primary goals rather than go on to treating more and more people. Yes, they are anxious. Yes, they are depressed. For that matter, we should be giving drugs to every condition. I don't think that that's an indication for giving antimicrobial agents anywhere. That's exactly where we are in terms of antimicrobial resistance, because people are giving antimicrobials for bacterial infections, even though infections are mostly viral. I'll stop here. Thank you.
We'll have 2 or 3 audience responses. Anyone who would like to give an argument which has not already been given?
Dr. AC, I have one rebuttal to Anil's statement about spouses. The transmission rate between spouses is high. If you look at blood donors and if you look at their spouses, most of them are anti-HBs positive, not HBsAg positive. And those spouses who are HBsAg positive usually have a family history on their own side. So between adults, sexual transmission can occur, but it's not the same as saying the spouse becomes HBsAg positive and then again is at risk of chronic liver disease. Most spouses are anti-HBs positive if you look at healthy blood donors as the group in which you can actually see this. The second point I'd like to also emphasize is about the fact that why do we just need to stick to ALT and DNA? We have other measures today. We have FibroScan, we have other fibrosis assessments, which can decide whether patients need treatment or not. I think that should be the criterion. It's not like somebody has DNA and therefore he needs to be treated. Somebody has DNA and does he need treatment? And it's not just ALT that we have. Today we have FibroScan. I'll put it to you, in any of the indications that you mentioned that you want to liberalize indications, you have a FibroScan of 5. Would you still treat?
Thank you, Shiva. Yes, Ashish.
I have just one comment to Dr. Rakesh, sir. He said, you said that all those who have DNA integration has already occurred, but DNA integration is not a one-time event. So if the DNA levels are high, more and more hepatocytes will get infected and it will get integrated at different sites, different parts of the DNA. So it's, if we suppress the DNA, then integration would certainly reduce.
Thank you, Ashish. Yes, sir.
I want to ask, we have liberalized.
You are not asking questions now. You can give a comment if you want, which has not been discussed.
Regarding liberalization of treating acute viral hepatitis B, what is your comment?
Thank you. Dr. B.C. Sharma.
I have queries to Dr. Rakesh Agarwal. One thing is that you mentioned about drug resistance. See, a patient with compensated or decompensated cirrhosis is HBV positive. Maybe in compensated cirrhosis, they are given anti-HBV treatment and their lifespan is normal. For whole life, they are given. Second is HBsAg positive, just walking and normal, but his family member has HCC. He is also given HBV, anti-HBV treatment, and he also takes lifelong. Those two groups, we are not worried about drug resistance. Why in others? And then the studies you mentioned about one drug versus combination. In that one drug, half of the patients lost HBV DNA as you have shown. So they were given HBV DNA treatment, antiviral, for a limited time. In that only half of the subjects, they lost it. Then if you go for a longer time, the more they will lose, and so less transmission will be there in that. And then you mentioned about immune tolerance phase, and you said the studies, in immune tolerant phase, 10:5 to 10:7 is the HBV DNA. For earlier studies, you said 200,000 something was there. But in highest HBV DNA, it's seen in immune tolerant phase. And secondly, immune tolerant phase, HBV DNA does not fluctuate much. You said today it is this much interaction. After 2 years, this will immune tolerant phase, it does not happen. It remains constant and stable. There are 5-6 points I.
Thank you very much, sir. Audience, would you like to now vote that you want to shift to Chinese guidelines? Anyone? Please raise your hands who want Chinese guidelines.
Sir, the debate was on liberalization, not on China. That is a political statement, Anand. That's bad.
How many want it to be
It was not a
liberalized?
Chinese chapter. It is a liberalization of the treatment.
Okay. How many want to treat all patients who are DNA positive? Okay, number has increased. Final answer from the chief judge.
I don't have a... that's a very important question. How many don't want to treat all patients and follow the guidelines? Guidelines only say you have virus is replicating, and there is evidence of disease. 3 things, 2 out of 3. Evidence of disease, raised ALT, histology. What has happened? Why this debate has happened? That you should see the World Health Organization figures, which none of you presented. That in 2022, there were 1.1 million deaths because of HBV. There are 82,000 liver cancer because of HBV. There are 254 million HBV carriers, out of which 65% are in Africa and Western Pacific region. And total global coverage of vaccination is 45%. And in this high endemic area, the coverage of vaccination is 15%. And therefore, if people in high endemic area thought that is very well known that all infected people are not being diagnosed. They are not being tested. And both of them has shown that a quarter of them are getting tested. And few of them are getting treatment. That is 10% are getting treatment. Obviously, how this 254 million carrier will reduce? How this decrease of mortality of HBV will reduce? How this cancer rate will reduce? Despite geographical features, this worried many people. And therefore, the concept of that at least let us liberalize the indication of treatment, go beyond the guidelines. And second thing, link treatment with testing. We are doing test and calling back, it should be automatically. That's what actually liberalization means, Rakesh and Anil. And that is what World Health Organization has told. And they have further gone ahead a step. That you are searching for DNA, it's not available. You are searching for liver disease, ALT, which is controversial, 13, 19 you are defining. And some places is more. Histological changes. You need liver biopsy. There are indirect evidences. So say liberalization of indirect evidence. What other guys can say? Use APRI, use fibroscan, right? If APRI is more than 0.5, if LSM more than 7, they say treat without DNA, without LT. That is the first thing. We both didn't say that. And the fibrosis, they say APRI more than 5 and LSM more than 12.5. This is widely available. If HbA1c positive, this you take. Alternatively, any ALT elevation which Rakesh showed last point or Anil showed, without DNA, if HbA1c positive, treat. They are liberalizing this. This beside the previous fact that ALT, DNA, evidence of histology, family history, pregnancy transmission, extrahepatic disease, all those standard indications exist. They are liberalizing in this area. The purpose is, can you treat all these patients without available diagnostic method? What do you say? Both will say. That is the purpose. So why you are arguing?
Sir, can we have the winner of the debate, sir?
I think we'll conclude the debate by saying that both spoke very well and both are winners. Thank you.
Thank you for that fantastic debate, sir. Thank you to the judges and the chairpersons as well. I just wanted to announce that we have a parallel session on HCC going on in Hall B at present. And in the interest of time, we will be not holding a tea and coffee break, but we have the counters open in case you would want to visit them outside.